So I know everybody in the room here. I know pretty much everybody that's on Teams here. But for those of you that don't, my name's Zach. I'm one of the cardiology APPs here at the Pavilion. And today's little lecture, little chalk talk is going to be on the clinical emergency of flash pulmonary edema. So starting off a little case presentation, 60-year-old male with significant pulmonary or past medical history of CAD, ischemic cardiomyopathy, last known EF of 32%, chronic congestive systolic heart failure requiring multiple hospitalizations over the past year, and remote history of renal artery stenosis. He was initially admitted to the PCU for acute decompensated heart failure and volume overload. He has undergone initial diuresis with minimal urinary response. On morning rounds, you notice he is now presenting with acute respiratory distress associated with chest pain and lightheadedness. So at bedside, you get your initial vitals, not great. He's tachycardic to 130, BP showing he's severely hypertensive with a systolic pressure of 210, diastolic 120. He's hypoxic with a pulse ox at 86% on room air. He is afebrile at 98.6, and he is pretty severely tachypnic with a respiratory rate of 34. Your physical exam at bedside, so he shows he is awake, alert, and oriented ×3, but in obvious respiratory distress with significant accessory muscle use. Speaking in 1 to 2 word sentences only. He has decreased breath sounds bilaterally with notable rales and rhonchi bilaterally as well, probably up 2/3 of the way on both sides. Given that he is in respiratory distress, we paged respiratory, who was able to get an ABG at bedside, showing a pH of 7.27, CO2 of 69, and a PaO2 of 45. So with this showing he is in some type of respiratory acidosis given the pH and retention of CO2. We get a bedside EKG given the tachy to 130, but it showed he was in sinus rhythm, no obvious ischemic changes. And then we got a chest x-ray stat on the floor showing the following. So even if you aren't familiar with reading EKGs, you can kind of see right off the bat bilaterally we have white all over the place, right? If this was pneumonia, it'd usually be consolidated to one spot. If this is pleural effusion, you'd kind of see it, a nice little arc maybe on one side, but this is all over the place, and white on an x-ray usually means some type of pulmonary edema, and that's what we see here, and it's in both lungs up and down, right? Whoop. So what's going on here? Is it time to panic, right? For anyone in the room, anybody that's listening, can anybody chime in and tell me what they think is going on with this patient? I'll give you a hint, it's the name of the lecture today. Flash pulmonary edema, right? Why is it doing that? So no wrong answers. Initially, would you treat this patient with A, aspirin, page interventional for a consult, B, start a nitro drip, or give sublingual nitro, C, give Lasix, D, give morphine and pray, E, call Zach as he should know what to do, or F, no idea, right? No wrong answers. Anybody want to chime in what they think they should do? Lasix, that's a good one. Anybody else?
You can call Zach. Yeah.
E works too.
And get that blood pressure down.
And get that afterload reduced, right? So obviously it's a little trick question. We can have multiple responses here, but we'll learn what to do as we go on here.
Use the mouse.
We're glitching, guys. Sorry.
You're doing great. I don't know why it's doing that.
Yes.
That's not Zach's problem.
Yeah. No, I think if you keep that's why when I use this one here, we always use the mouse because it's better.
Oh.
All right, guys, I'm using the mouse. I'm using it slowly. All right. So acute flash pulmonary edema, also referred to as SCAPE. Not common, but it will be referred to as that. So sympathetic crashing acute pulmonary edema. Those two terms are synonymous with each other. Acute flash pulmonary edema is a clinical medical emergency categorized by a particular dramatic form of alveolar pulmonary edema related to a sudden rise in left-sided intracardiac filling pressures. Flash pulmonary edema is going to be described as an abnormal vasoconstrictive and endothelial dysfunction, triggered primarily by an exaggerated degree of our RAS system, both from a pulmonary standpoint and a systemic standpoint. So going back to school, your RAS system is your renin, angiotensin, aldosterone system. and you also have a decline in your nitric oxide production. So if we look at this little picture at the top, this is pretty generic pulmonary edema, right? That's a normal alveoli with gas exchange. This is when it fills up with fluid. Flash pulmonary edema is when this is very significant and fills up very rapidly, limiting pretty much all types of gas exchange, right? And then these are the things that are going to be released, triggering our RAS system here: angiotensin 2, catecholamines epi, and norepi. So when we talk about somebody that's flashing, we commonly kind of group a lot of these terms erroneously into the same group and kind of put them all under the same umbrella, right? I've heard people kind of refer to, this patient's flashing, they're in acute decompensated heart failure, they're having bilateral pleural effusion, right? But that's not particularly correct, right? When we consider somebody flashing, I think somebody has their microphone on.
Okay, hold on. I'll check.
All right. So when somebody's flashing, we really want to differentiate flash pulmonary edema from kind of all these other symptoms right here, right? Flash pulmonary edema and acute decompensated heart failure is something we see all the time. They do have a lot of similarities in kind of the way they present, but flash pulmonary edema, the biggest takeaway from today is you have to treat this as its own entity because it's going to present very, very differently from a lot of the rest of these here. So it's not an umbrella term. You want to use flash pulmonary edema all by itself. So getting into the pathophys, at a micro level, a lot is happening, but I kind of wanted to keep it meat and potatoes today, more at a macro level. So this is a little diagram I put together, basically outlining our vascular system, right? We have our heart, pumps out oxygenated blood to our body. We get the return to our right side, oxygenates in our lungs, and then returns, right? The thing with flash pulmonary edema, we're often dealing with some type of cardiac insult, something that has to deal with a weak heart and something on our service that we see a lot. And they can present very differently. So these blue triangles are fluid, supposed to represent fluid. So we get a little trigger, puts fluid in our lungs, we have increased pressure, right? Whenever we have fluid in our lungs, our body perceives it as we're almost like drowning from the inside, right? We get hypoxic. It puts a lot of stress on the pulmonary vasculature, right? Stress. Anytime we have a stress response, that triggers the fight or flight, and we get these gnarly hormones, epi, norepi, vasopressin, angiotensin, all of which work to kind of clamp down on the peripheral vasculature. That leads to here, clamping down here, and it kind of leads to this gnarly cycle here. We get more fluid in the lungs, right? Because then we get increased afterload. It's very tough for the ventricle to push against, which leads to a backflow of fluid up into the lungs, right? This is all a pressure system, right? So if one part is clamped down, the fluid can only flow one way, and that's backwards. So we get more fluid in the lungs, which releases more stress, more epi, more angiotensin, and then more clamping down of our vasculature, right? And that's really flash pulmonary edema in a nutshell, and this is a very acute process. Now, this can happen in just acute decompensated heart failure over time, but that's kind of like the main difference between acute decompensated heart failure with pulmonary edema and flash pulmonary edema. One's more chronic and we can compensate for it. This one is something that's causing it very acutely. So this is the pathophys, just basically put into words with a nice little picture here. So stage 1, we have some type of cardiac insult that's causing increase in left atrial pressure reflected back up into the pulmonary vasculature. Stage 2, pretty much classified by a rapid increase in interstitial edema. And then stage 3, we essentially have alveolar flooding and decreased gas exchange. And that's where we're really going to see it in the patient with presenting with hypoxia and dyspnea. So this right here is your pulmonary capillaries. It surrounds your alveoli. Increased hydrostatic pressure, right? So we kind of do it with our wedge. A wedge is a reflection of our left end diastolic pressure. So that is reflected back up into our capillaries here. So increased pressure, and that fluid has nowhere to go but to cross this barrier into the alveoli, right? So increased pressure, it's literally pushing against the walls, pushing fluid into a space that it should not be. This should be nice and empty. This part right here should be nice and empty for gas exchange. When you fill it up with fluid, it's going to be very difficult for O2 and CO2 to exchange with each other. We're going to get hypoxic, respiratory acidosis. Not a good path, right? A little tidbit here, just in terms of, people that think like, chronic CHF, it's kind of, people can compensate over a longer period of time that have increased pressures. They don't have to be flashing. people can compensate by kind of building up a fibrotic wall here to kind of prevent some of the fluid from crossing. And people with chronic CHF also have a more robust lymphatic system, which helps kind of drain this fluid when needed. So those kind of people are patients. Most of them are kind of able to compensate. It's when this patient, it happens acutely and they're not able to compensate that this becomes an issue, right? So increased pressure, alveolar flooding within the capillary space and the alveoli. So causes. The causes here are, some of the main ones are here in red, but I outlined some of the ones we see the most and are the most severe. Causes bilateral renal artery stenosis or unilateral stenosis in somebody that has a solitary kidney. Acute severe valvular regurgitation. We see a lot of people on CAP-I that go for mitral valve repair, mitral valve disease. This is a huge one here. Acute cardiac structural causes, ruptured chordae tendineae, that's pretty much the muscle that holds down the valves to the papillary muscles in the heart. If that ruptures, you pretty much just have a flappy valve, causing some significant regurg. ACS, MI, muscle wall ruptures, apical aneurysms, and then malignant hypertension, which goes hand in hand with renal artery stenosis. So signs and symptoms, I'm pretty sure everyone here is familiar with signs and symptoms, but the biggest one here is going to be acute elevations in blood pressure due to that RAS activation I was talking about with the epi, norepi, and angiotensin. We're going to have sudden shortness of breath, acute dyspnea, tachypnea. These patients are literally going to feel like they're drowning or suffocating. A lot of times that's literally what they'll convey to you is how they're feeling. They're going to have significant orthopnea. They're going to have to be sitting up in bed at 90 degrees. Laying them flat is going to be nearly impossible. They're going to be wheezing with the cardiac edema, coughing up pink frothy sputum. Their skin is going to be cold and clammy because of that clamp down effect in the RAS system. They might be blue-gray in appearance from the hypoxia. They might have blue lips. Feeling lightheaded, dizzy, weak due to poor cerebral perfusion, and then anxiety. Anytime that you feel like you're drowning from inside out, I would be anxious too. So that's kind of like classic signs and symptoms for somebody that's flashing on you. Your initial assessment, this really isn't anything crazy. This is pretty much the baseline that we do for all our patients in any type of clinical emergency, but vitals. Vitals is a huge one, and you can do it right off the bat. If we think back at our initial patient, he was tachy to 130, hypoxic in the 80s, and tachypnic in the 30s, and also hypertensive, I think, at like 220. So right off the bat, you know this is a unstable clinical emergency for this patient, and something needs to be done right away. Physical exam findings, you can use your eyeballs. After you get your vitals, use your eyeballs. What's this person breathing like? Are they using their accessory muscles? Are they talking in 1 to 2 word sentences? What's their pattern? What's their breathing rate? Listen to them. Do they have crackles? Do they have rails? Are they at the point where you don't even hear any breath sounds? They're just limited gas exchange all throughout their lungs. Is this a significant volume issue? Look at their JVD, JVP. How high is it? Look at their peripheral edema. And then specifically with valvular issues, do they have a new systolic murmur indicating some type of new MR? You know, anytime you hear a systolic murmur, you're thinking aortic stenosis or mitral regurgitation. And then in terms of diagnostic stuff that you can get done, hopefully within the first 5 to 10 minutes, we can get a bedside EKG, chest X-ray, ABG, VBG, and then labs, basic labs. That's pretty much your initial assessment right off the bat. So treatment. The moneymaker for this. So left side is a pretty normal circuit here. The right side is, I put this in here, I thought it was neat. So this is like that clamp down effect that I wanted to kind of portray. And this is the fluid in the lungs. So our treatment is going to be based on reducing the systemic vascular resistance, the SVR, and getting that fluid out of the lungs. That is going to be the mainstay of treatment for flash pulmonary edema. Okay. So with that, we think back to our patient initially. There's a lot going on with this patient. A lot of times in clinical emergencies, a lot of people in the room, but we need to treat our ABCs, kind of put everything else out to the side and treat your ABCs. This person was hypoxic in the 80s, had an ABG that was showing respiratory acidosis. He needs to be on non-invasive positive pressure ventilation, right? This is for the PEEP. You know, we mentioned that there's a lot of fluid within the alveoli space. These patients really have no way of getting that fluid out unless it's with positive pressure and the PEEP, right? So first thing you want to do, if you get to the room, they're initially hypoxic, you can initially throw them on a non-rebreather, but these patients, we should be calling respiratory and they should be on a BiPAP fairly quickly, right? This is usually a respiratory thing, but just so that you guys know, we can always start off with a basic PEEP of around 6 to 8. But there's really no contraindication to titrating up fairly quickly to 10, 12, or even 14 if we don't see any type of clinical improvement within the first 5 minutes. So that's not something we usually do, but in the back of our mind, if you're looking at the machine and it still says a PEEP of 5 and they're looking awful, like, be like, hey, has anybody just considered going up on the PEEP, right? Putting more pressure into the alveoli, forcing more fluid out of the alveoli space. Okay, that's your first thing. Treat your ABCs, correct your metabolic disturbances with PEEP. Second, afterload reduction. We need to kind of blunt that RAS system activation that's happening, and this is often on our floor, we're going to be using nitro. Nitro here, there's different ways. It's usually provider preference. I've seen it done multiple ways, but we can all opt for sublingual nitro at 0.4 milligrams, which essentially comes out to 400 mics. And if you kind of do it by drip, they do recommend starting at a drip of 400 mics per, I think, a bolus of 400 mics every 2 minutes, and then reducing down to 100 and titrating up. So there's really no reason you can't start with a sublingual nitro right off the bat. The nurses I can put the order in, you guys can grab it, we can put it in their mouth, have it dissolve, and then reduce their afterload while they're on the BiPAP, right? That's clean. We can get that done fairly fast instead of waiting for a drip to come, titrating it, all that nonsense, right? But both are very effective. Just keep in mind that sublingual nitro works, and if we are going to use a drip, it's got to be a pretty high drip. I think our starting rate is like 5 to 400. We need to have a very, if you're going to do a drip, it's got to be high. Right? And then last thing is volume. So non-invasive pressure ventilation, afterload reduction, and volume. Those are your 3 pillars to treating flash pulmonary edema. So I put this in here as a little caveat. Our patients in particular, often it is a volume issue. But I don't want you guys just thinking that it's always a volume issue, because it's not. Flash pulmonary edema is not always a volume issue. It can be strictly an afterload issue that we have to reduce, right? So, but it's not a bad thing to put on. You can always put on 40 to 80 of IV Lasix and get the patient diuresed a little bit, get some of that fluid out and help them out a little bit. So in summary, acute flash pulmonary edema is indeed an acute medical emergency with a pretty significant mortality rate. Severe cases, you have about 5 to 10 minutes to correctly diagnose and intervene before these patients clinically deteriorate, requiring intubation or even CPR due to metabolic disturbances and respiratory acidosis. The classic patient is going to present with systolic blood pressures greater than 180, so they're going to be significantly hypertensive, they're going to be hypoxic, they're going to be in respiratory distress, crackles, rails, bilateral. That is going to be your picture-perfect patient for flash pulmonary edema. I just kind of touched on it. It often is an afterload issue, not a fluid issue. But in our patient population with these poor EFs and poor hearts, it may be a fluid issue. So keep that in the back of your mind. And it could be both, but often an afterload issue first. Goal of treatment, as we just went over, secure airway, ABCs, provide O2 via positive pressure ventilation. We want to reduce afterload ASAP with high dose nitro, can be either sublingual or drip. And if acute volume overloaded based on your exam findings and the patient clinical criteria, we can use a loop diuretic for these patients. Any questions? Did I bore everyone to death?
You mentioned sublingual nitro, but then you also mentioned high dose nitro. So like if we were delayed in getting the IV nitro, would you repeat the sublingual? If so, like how much or?
Yeah, so like I mentioned, the sublingual nitro at 0.4 milligrams is equal to 400 mics, which if we were to start a drip, we would start it at 400 mics. So actually the sublingual nitro, even though it's a little tablet, is a lot of nitro. If you don't get your clinical response right away, the way I've seen it done, the way I've talked to Bob, is we do the sublingual nitro, then put them on a drip. Because then it's easily titratable. We can start it wherever we want instead of getting that kind of like variable effect of the dissolving sublingual nitro.
You can have nature drips in your bony cells.
Yeah.
Speaking of, is there any like on the floor? Do you know, like, can we start a high drip nitro on the floor, or would that have to be?
I think for emergency we can start.
Yeah,
Yeah.
you can always, nitro pulse.
Nitro pulse in it.
Yeah.
You can always do that.
Crank that up to 400.
Any questions from the crowd?
No, just so in awe. It's just great lecture.
Yeah, very good. Thank you, Zach. That was awesome.
No problem. I mean, I was low key panicking, Ben. I definitely expected a few questions, but thanks, man.
But Alenia has some.
Alenia?
Okay. Patient in rapid AFib having flash pulmonary edema. what's your management? Do you do beta blocker or not?
Well, to be honest, it would be what is, in my mind, what would be triggering the rapid AFib, right? Is this person, like, what are their vital signs? Are they clinically unstable? We would have to treat that first, in my mind.
She's having
So why would
clinical
it be
picture. Why, she's having clinical picture of flash pulmonary edema. She's having AFib, RVR, but not like 200s or anything like that.
So to be honest, Ma, I would still kind of go with I would put them on oxygen, I'd put them on the BiPAP.
Okay.
I would reduce the afterload, see if that kind of corrects the problem, and if not, Amy kind of whispered it, I would maybe opt against medical treatment and maybe try to stabilize them and cardiovert them.
Yeah, the reason I'm asking is,
What happened? What was the question?
Rapid
So,
AFib.
Alania asked a great question is, what do you do with a patient that is flashing, but you also notice they're hemodynamic unstable in rapid AFib RVR, which is very common. It can happen, especially with volume overload, it can trigger.
The atrius to go berserk.
So,
the reason I asked this question is I just want to make sure to point across about use of beta blocker in flash pulmonary edema, especially if you're talking about cardiogenic shock, you're not supposed to be using.
So you
That's
said
why I was asking, just wanted to make it a point.
so beta blocker.
the beta blocker?
No,
Oh, no
Contraindicated.
beta blocker.
Contraindicated.
Right.
especially if you're thinking
Right, because
cardiogenic.
it's not for,
Yeah.
sorry.
Especially like, yeah, we've touched on all, like our patients already have very severe.
The reason I'm sharing this is I've done simulations of cardiogenic pulmonary edema, like always, they see the rapid heart rate, they treat that right away.
Right.
Makes sense. Interesting. It's so true.
Yeah.
And my initial thought would be if they're hypoxic and you
Yeah.
really are concerned for flash.
You know, everybody
I would
will
think
do
that would be
basics and all that stuff, but it's so crazy that when you go into a room, you see, especially if they're in this kind of, in this floor, and they would see that rapid, something rapid in the telemetry, they act on that right away, and their first instinct is give IV beta blocker. No, you're not
Yeah.
supposed to do that. You're gonna make it worse.
Right.
Very good.
Okay. All right, squad. That's flash pulmonary edema.
Thank you,
Thank
Zach.
you.
Thanks,
All right,
Zach.
cool.
Thanks for the chocolates, Mayor.
Take chocolate on the way out.
Yeah. What's next? I'd rather do this.